Dear students, welcome to the session on anemia in pregnancy. I think this is one of the hottest topics from the time when I was a student, probably to the time when I am now the examiner for many of the exams. Even today, it enjoys the same reputation, anemia in pregnancy. And I would call it, unfortunately, the hottest topic because in our country, latest survey has revealed that the problem of anemia is almost the same for the past 5 to 10 years. Pregnancy with anemia is to the tune of between 45 to 50%. Some of the areas, some of the geographical zones having somewhere close to 75%, and some of the states having somewhere around 40 to 50%. If I go to the learning objectives for today, let's understand what do you mean by anemia in pregnancy, because it slightly differs from anemia in non-pregnant women and men. How to classify anemia, effects of anemia on pregnancy, their complications, and I have stressed more on the nutritional part, that is iron deficiency anemia, which is quite rampant in our country. In fact, we go to the extent of telling whenever you get a pregnant woman with anemia, straight away conclude that it is a case of iron deficiency anemia and go ahead with the treatment. This is called presumptive. Hello? Anything?
Yeah. Sir, the slide is not moving. I guess you need to manually move the slide. Click on slide number 2 from the mouse, sir. Using the mouse, you may click on slide number 2.
I'm actually using a laptop without a mouse.
Yeah. So using the laptop, using the cursor,
yeah.
you may click on slide number 2. It's on the left side of the screen. I can't see your cursor, sir. Yeah. Yes. That's how you do it, sir.
It's fine now?
Absolutely, sir. Absolutely. Now you've moved to definition.
Yeah. We go on to the definition of anemia now. Anemia has got various definitions. In fact, you can't give a particular level and say that this is anemia in pregnancy, because at different points of time in pregnancy, in different ages of women and different trimester of pregnancy, it's going to change. And thus we have a statistical definition which says that it is the hemoglobin value which is below the 2 standard deviations of the median value for a healthy matched population. If you consider a particular, say for example, a first trimester woman who is around 25 years, hailing from one particular geographical area, in that same zone, same duration of pregnancy, in that same age group, you take the women, and if the hemoglobin is less than 2 standard deviations for that age, for that sex, for that trimester of pregnancy, then you can consider that as anemia. The simple definition, I think it was a little bit confusing. The simple definition would be, remember, first trimester and third trimester, 11 gram per deciliter is taken as the normal hemoglobin level. Anything below this is taken as anemia. In the second trimester, because you have a kind of concept called physiological anemia of pregnancy, I'm going to elaborate a bit on this little later. So we have a threshold of 10.5 grams per deciliter as the cutoff to define anemia in pregnancy. Right? The Federation of Gynecological Societies of India, FOGSI, takes a cutoff as 10 grams. The severity of anemia, once you make a diagnosis of anemia, you are going to say whether it's a mild anemia, moderate, severe, or very severe. ICMR has given a definition which most of us follow. Mild anemia is between 10 to 10.9 grams per deciliter. Moderate anemia will be 7 to 9.9 grams per deciliter. Severe anemia is 4 to 6.9, and less than 4 grams is considered as very severe anemia. So this definition and this classification you are supposed to remember thoroughly, because it's usually a very commonly asked question in the exam, right? The incidence of anemia I just now mentioned, it's somewhere between 45 to 50 in India. Globally also, it's about 40 to 50%, and of which 25% contribution is from the developing countries. In India, certain areas has 80 to 90% of the pregnant women with anemia. Of course, it could be a milder form. So in fact, the latest NFHS survey that was done in 2020-21 has shown that mild anemia cases have increased in our country. In US, it could be just 5%. Central Africa, it could be around 60%. And in non-industrialized countries, developing countries, anemia is associated with 13% of maternal mortalities. Kindly remember, students, anemia is an indirect cause for maternal mortality. A normal hemoglobin level protects the woman from death during pregnancy and childbirth with varieties of complications. Anemic woman, if she has a postpartum hemorrhage, she has a higher chances of dying compared to a woman whose hemoglobin has been normal. Now, we go to the classification of anemia. So, to classify anemia, we have, I have just conveniently divided it into the problems that can occur at production level, which can occur due to blood losses, and the red cell loss that occurs because of destruction, right? So production involves two issues. The first thing is the availability of raw materials for the production of RBCs. Number two is the site where it is produced. So any problem at the site of production or the raw materials required for production, which is the commonest cause. You can have decreased red cell mass and you can have anemia. Similarly, blood loss, it is very, very self-explanatory when the woman loses blood. Yes, by any route. It could be a hemorrhoids, it could be hemoptysis, hematemesis, increased menstrual blood loss before pregnancy, or blood loss during pregnancy itself. All these things can make her anemic. The third thing is about destruction of red blood cells within the body, which we use the word hemolytic anemias, which can be a congenital one or acquired condition, right? So continuing with the classification, nutritional wise, related to production, we very well know the production of hemoglobin requires iron, folic acid, vitamin B12, and many of the trace elements, or many a times combined iron, folic acid, vitamin B12 deficiencies. So these can cause anemia. So this is the basis of nutritional anemia in pregnancy. Now, anemia associated with decreased production of blood cells because of the site problem, production site. So bone marrow disorders, then you can have bone marrow suppression, maybe an infection induced or drug induced or immunological. Any of these things can cause bone marrow suppression, and many a times bone marrow suppression may not just result in anemia, it results more often in pancytopenia. Chronic renal disorders, which again brings down the level of erythropoietin, and the production at the site is again altered. Of course, hypothyroidism too works through the same mechanism. Then coming to anemia associated with increased destruction of blood cells. I just mentioned, we call it hemolytic anemias, and the commonest ones that I expect our students to remember would be sickle cell anemia, thalassemia, hereditary spherocytosis, which are inherited. Acquired ones are autoimmune acquired hemolytic anemia, sometimes hemolytic anemia associated with thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, chronic infections which cause hemolysis, right? So these are, and even hemolysis caused by malaria, all these things are acquired hemolytic anemias. Anemia due to blood loss, pre-pregnancy heavy menstrual bleeding, gastrointestinal bleeding, or obstetric hemorrhages. Most often students, the woman enters the pregnancy with anemia and with a low hemoglobin and continues to be worsening during her pregnancy, right? So pre-pregnancy hemoglobin optimization is a very important strategy before a woman attempts pregnancy. Now a word about physiological anemia of pregnancy. You know, the blood volume has to increase in pregnancy for various reasons. There is a need for extra blood to the uterus and placenta, and the vascular enlargement, dilated vascular system, the peripheral resistance being less, the intravascular volume is more, so it needs to be filled with blood. And to protect against the anticipated blood loss during pregnancy, these are the natural mechanisms by which the woman is protected from adverse events due to blood loss during delivery. So the blood volume has to increase. But what happens while the blood volume is increasing, the plasma volume versus RBC mass volume is disproportionate. Just understand this. Plasma volume increases by 40 to 50%, but RBC mass increases by only around 30%. So there is a discrepancy of 10 to 20% between the increase in the RBC mass versus the plasma volume, which causes a dilution. This dilution eases the circulation, actually keeps the blood volume good, and it is in fact a protective mechanism for the whole of pregnancy. It has to occur. So we don't make any attempt to correct this or to prevent this. Thus, this is called physiological anemia of pregnancy. It has to happen. Hope you understand this concept. And that is why the mid-trimester, from where you always expect a rapid change in the hematocrit of the patient, that is the time when you expect the lower threshold for hemoglobin when we define anemia. That's why we have kept 10.5 as the cutoff for mid-trimester, right? Commonest form in pregnancy, which is a presumptive diagnosis, is iron deficiency anemia. I just mentioned it earlier also. So it is a presumptive diagnosis. We always say that whenever a pregnant woman presents with low hemoglobin, the first thing that I consider is iron deficiency anemia. So what are the causes for iron deficiency anemia in pregnancy? The most important is inadequate intake, right? Unfortunately, whatever diet that we expect our women to take, or whoever takes for that matter, is not adequate enough to meet the requirement of a pregnant woman of the iron. Non-pregnant women and men probably require about 1 to 1.5 milligrams of iron per day per kg, and this is going to be provided by the intake of the diet that routinely is done by everyone. Whereas in pregnancy, the requirement is more. So the diet alone becomes highly inadequate to meet with the requirement of iron, unless she has a very good store of iron, which is unfortunately not the case in our country. So most of them, if we don't supplement them with iron, they are going to become anemic because of inadequate intake, and even whatever that they take may have low bioavailability. You know, the vegetable sources of iron have a low bioavailability compared to the non-vegetarian sources. Diets with low iron content is the important problem, and also the ones which come in the way of absorption, defective absorption due to phosphates, phytates, tea, coffee, etc. Deficiency of vitamin C, which is very important in the absorption of iron. The loss of blood, of course, it may not be very conspicuous. You may not be very obviously seeing the blood loss through the stools, but it could have been sucked by the number of worms in the intestines, ankylostomiasis, which can cause anemia in our country, right? And short interpregnancy interval and multiparous nature of our women also makes them more prone for anemia. So these are the usual causes. When we take the history, it's very important to obtain what is the diet that they are taking and what is the exact share that the woman gets. Though they may be cooking daily non-vegetarian food, but just ask that lady whether she is able to take some amount of that non-vegetarian food. Probably she would say, no, after my mother-in-law, father-in-law, brother-in-law, that one, this way, everyone finishes, I would be left with a cup of rice with some kind of rasam or something, which doesn't give her anything. So though if you ask her what they cook, but you ask her what she eats, there would be a lot of difference between the two, right? And about when we talk about hookworm infestation, a very important information that you are supposed to obtain is about pica in the first trimester, and also barefoot walking, open defecation practices. Thanks to the national programs, I think this problem is reasonably ousted out from our country almost, right? And some malaria endemic areas, there could be infestation, rather the malaria infection causing anemia. And of course, when you take the obstetric history, you would know about interpregnancy interval and multiparous nature of the woman. Now, effects of anemia on pregnancy, preterm delivery, puerperal sepsis after delivery, they are more prone for thromboembolism, which can kill the woman. They are prone for postpartum hemorrhage, poor tolerance to blood loss. Whatever little blood loss that occurs during pregnancy or delivery is not tolerated by them. They are more prone for postpartum depression too, right? So these are the effects on, it's not just puerperal sepsis, they are overall more prone for infections. It could be antenatal urinary tract infection, right? So it's quite common. Respiratory infections, they are common. Coming to fetal and neonatal consequences, abortions, preterm birth, and death of the newborn babies, perinatal mortality, low birth weight, and it could be a small for gestational age or fetal growth restriction, poor mental and psychomotor performance of these children, low iron stores in these children will predispose them for anemia of infancy and childhood. And imagine it's a girl child. The mother is anemic. The child that is born will be anemic. She goes into adolescence, then starts having her menstruation. Then she becomes pregnant. She enters the first pregnancy itself being anemic. This is how it just goes as a cycle, right? So in case you have a severe anemia, then non-reassuring fetal heart rate patterns, reduced amniotic fluid volume, fetal cerebral vasodilatation, and of course, even it can result in fetal death. Mild to moderate anemia, the woman can present to you with easy fatigability. This could be the only symptom with which a woman present to you. If it is a sudden blood loss anemia, they may present with syncopal attack. She may present in shock with tachycardia and feeble pulse, then even hypotension, unconsciousness, etc. But most of the anemia cases that we come across, the woman is usually well compensated. She learns to live with the anemia. So accepting that she gets fatigued and with strenuous work, she may feel breathless, there won't be much of a important symptom. It becomes so difficult sometimes that you even suspect anemia, because even in pregnancy, women normally can have fatigability, breathlessness, exercise intolerance, giddiness, palpitation, physiological edema. All these things are common. But in anemia, unless you examine the woman, unless you look for pallor, unless you look for other signs and symptoms like platinikia, koilonychia, etc., you may not be able to even suspect anemia. This is how many of them go missed, and they present in labor, present with some life-threatening conditions, right? The greatest threat to the life of the woman is with congestive cardiac failure, and it is a high output failure. Heart tries to pump as much as possible, and at one point of time it says, no, I can't do any more, and the heart fails. So she can present with acute pulmonary edema and other features of right heart failure also later, right? So what do we see on physical examination? You see pallor of mucous membranes, you see spoon-shaped nails, koilonychia as a later stage. Initially, it will be a platynychia, glossy tongue, atrophy of lingual papillae. Many of these symptoms are associated with other vitamin deficiencies too. And it's not that she will be deficient only in iron. That's why combined deficiency is more common, and you have to look for the head to toe examination for all the deficiencies, the luster of the hair, the changes in the skin, the sclera dryness, and any kind of vitamin A deficiency symptoms, angular stomatitis, glossitis, cheilitis. Everything has to be looked in detail when you are examining an anemia case, because you may correct iron deficiency, but unless you correct all the other deficiencies, you may not be able to have a good success in treating this anemia. You may get a splenomegaly here, and the moment you get splenomegaly or hepatomegaly, your diagnosis should be reviewed. Don't just keep thinking that it is iron deficiency. If you have splenomegaly or hepatomegaly in your patient, you think of in endemic areas, it could be malaria, or it could be a very important feature of hemolytic anemias. Then flow murmurs, right? Usually systolic murmurs less than grade 3. Beyond grade 3, we take as pathological, but these are hemic murmurs. Diastolic murmur is always pathological, but here it is a systolic murmur less than grade 3, and you may find both in both outputs, that is right ventricular and left ventricular. You can find both in pulmonary area and aortic area. And in very severe cases, you can have the signs of cardiac failure, generalized edema, pedal edema, tachycardia, hepatomegaly, crepitations at the lung bases, or she may be tachypnic, and sometimes we have even seen patients coming to us with frothy sputum, that is red frothy sputum, suggestive of acute pulmonary edema too. So what do we do? How do we make a diagnosis or confirm the diagnosis? See, I have written some of the simple things that has to be done. Please do not forget. Don't keep on telling advanced investigations in the exam. When the examiner asks you, you have to do a complete blood count with RBC indices. That's going to tell you very important informations with what anemia we are dealing with. Peripheral smear is a very important necessity. It tells about whether it is a microcytic hypochromic anemia, macrocytosis. Then do you have abnormal cells? Do you have immature cells? Do you have polynuclear, polynucleated neutrophils, which will give a clue about megaloblastic anemia? You may find parasites also. So we may ask you, what's the importance of peripheral smear in the diagnosis of anemia? It may tell you the type of anemia. Sometimes it can also tell about the cause of anemia. So that's the importance of peripheral smear. I have put the next investigation in red. It is not absolutely necessary. Iron studies like serum ferritin, serum iron, and TIBC are not routinely done. Only only when the patient doesn't respond to the routine supplementation of iron, or you are suspecting that it is a case of hemolytic anemia, not nutritional, you can just do these tests to prove your diagnosis. The next two important examinations are stool examination for ova, cyst, and occult blood. Occult blood can tell us that she is losing blood. Ova and cyst can make a diagnosis of usually ascariasis, trichuris infection, and even ankylostomal infection, and which will help us to treat her. In fact, whether you are able to find the ova cyst or not, we always treat every pregnant woman. It's a part of our national program with a tablet of albendazole 400 milligram or mebendazole 500 milligram once, at least in the second trimester. right? Urine microscopy and culture and sensitivity are very important because of the link between urine infection with anemia. Urinary tract infection is more often encountered. It could be asymptomatic bacteriuria, which is picked up only on lab examination in anemic patients, and anemia per se is known to predispose for urinary tract infection. And UTI can cause anemia. So we should be extremely careful in ruling out and treating effectively the UTI, right? Special investigations are required only in certain cases. It could be hemoglobin electrophoresis, demonstration of sickling, estimation of folate level, vitamin B12 levels, etc., which may have to be done in selected cases. Now, you have done these things. How do we pick up the difference, right? See, when you are looking at the RBC indices, I have just highlighted 2 points here. Rest of the things, it's the hemoglobin. Hemoglobin values are almost always decreased in iron deficiency anemia, megaloblastic anemia, and thalassemia. But the difference that you see is about the mean corpuscular volume, right? Megaloblastic anemia, you have got big cells, so the MCV is increased and MCH is increased, but MCHC is most often decreased in all the conditions, right? So this is how we differentiate. And coming to the further investigations, here also the ones that are put in green, please observe, serum iron is decreased definitely in iron deficiency, but in thalassemia and in megaloblastic anemia, it could be normal, and most often in thalassemia, it is increased. That is the reason why we do ferritin levels, TIBC levels, etc., when the patient is not responding to iron, to find out, is it something else which is not iron deficiency? If not iron deficiency, and if you find high ferritin, how do you find ferritin? Because of destruction of RBCs, the released hemoglobin releases iron into the pool, and the excess iron is stored as ferritin in the body. That is how thalassemia or sickle cell anemia, you have higher levels of iron in the body in the form of ferritin, right? The next one is about hemoglobin. Fetal hemoglobin percentage is high in thalassemia, and that will be around more than 2%. Serum folate is decreased in megaloblastic anemia. Red cell folate is decreased. Serum B12 is decreased in megaloblastic anemia, which are normal in IDA and thalassemia. When you look at the bone marrow, you usually find erythroid hyperplasia in IDA. Then you have increased iron in the bone marrow in thalassemia, and you find macrocytes with erythroid hyperplasia in megaloblastic anemia. And of course, peripheral smear, I have already told what are the differences. So how do we prevent this condition? It's one of the conditions which is highly preventable. Please understand, whenever we talk about maternal mortality and the cause for maternal mortality, if you find that anemia was a pre-existing condition, in most of the cases, it would be a preventable mortality, preventable death of the mother. How? Demand for absorbed iron increases steadily during pregnancy. This is what I told you. Initially, it will be close to 1 milligram per day, 0.8 to 1 milligram per day. But once she reaches the mid-pregnancy, 20 weeks onwards, it goes to about 6 to 8 milligram per day. In the third trimester, it will be close to 8 milligrams per day. So first trimester, roughly 1 milligram. Second trimester, 4 to 6 milligrams. And third trimester, 6 to 8 milligrams is the requirement of iron by the pregnant woman, right? So if you just take an average, she requires roughly about 6 milligrams per day, excluding the first trimester. We don't even treat her with iron in the first trimester. Hope all of you are aware. Only because 10% of elemental iron is absorbed. So what we have to minimum give is 60 milligram of elemental iron has to be given for every pregnant woman to get that 6 milligram. Just look at the last sentence. dietary iron is highly inadequate to fulfill the demands in the second and third trimester. So first trimester, you just manage her with diet, and I don't know how successful we will be because she may have vomiting or hyperemesis sometimes. So, but still, because she requires only 1 milligram per day, which is equal to the pre-pregnancy requirement, she should be able to manage with that. But beyond that, you need to give prevention. This is the rationale behind the National Anemia Prevention Program, which gives prophylactic iron to all women. Please remember, students, there is something called prophylactic iron. There is something called therapeutic iron, right? They are not same. Prophylactic is given to every pregnant woman, whereas therapeutic iron is given to only women with anemia. Please understand this difference. Then you have to give some general advice to every pregnant woman. Advise her to take diet rich in iron like green leafy vegetables, sprouts, dry fruits. They can change jaggery. They can use jaggery instead of sugar. Then red meat, liver, which are very rich sources of iron. And they have heme iron, which is very much well absorbed. And the practices of cooking in iron vessels, avoiding overcooking, avoiding open defecation, and avoiding walking in barefoot, right? These are the other practices that should be observed by them. So supplemental iron, WHO guidelines have recommended the following: provide iron to all pregnant women. Iron should be started from first antenatal visit. And you know what we follow is around 14 weeks we start, 13 to 14 weeks we start. In India, WHO recommends daily 60 milligram of elemental iron in the form of ferrous salt along with 400 microgram of folic acid for 6 months during pregnancy. Please underline the word at least. It is not just 6 months. It is not just 100 tablets. It is at least 6 months during pregnancy and at least 3 months during the postpartum period. So this is the minimum recommendation by WHO, and you have a slightly different recommendation by the government of India, which recommends 100 milligram of elemental iron and 500 microgram of folic acid. Students, just go and check in your hospitals what is the tablet that is available in your stores. It could be this kind of ferrous sulfate, that is 100 milligram, giving 100 milligram of elemental iron, 335 milligram of ferrous sulfate with 500 microgram of folic acid, given at least for 100 days from 14 weeks to all pregnant women, right? So though WHO gives 60 milligram, Government of India recommends 100 milligrams of elemental iron in the form of 335 milligrams of ferrous sulfate, right? They are provided free of cost by the government. And as I told you, parasite control measures, if the parasitic infestation rate is more than 20%, because it is so in India, albendazole or mebendazole are given to all these women. Coming to the treatment part of iron deficiency anemia, we have got three kinds of treatment options. You can give oral iron, you can consider injectable iron, or you can go for blood transfusion or packed cell transfusion. It differs from patient to patient, trimester to trimester, and severity of anemia. So what is that? We have to know. Oral iron therapy is the first line. What I'm talking now is therapy. It is not prophylaxis. What I spoke till now was prophylaxis, which is given to every pregnant woman. Whereas what I'm talking now is the therapeutic approach to diagnosed anemia. The first line of treatment is oral iron. It is cost effective and inexpensive. Oral dose of 120 to 200 milligram of elemental iron. Please remember, for prophylaxis, I used to say 60 to 100 milligram elemental iron. For oral iron therapy, it's almost double, 120 to 200 milligram per day. It could be BD or TID dose. Why I have written BD or TID is that if we are giving 60 milligram tablet, you give 3 tablets to cover around 180 milligram per day. If you are using 100 milligram elemental iron providing tablet, you can give twice daily. Beyond which, there is a beautiful mechanism in our intestine to throw away the iron. If it goes beyond 200 milligram elemental iron, it cannot absorb more than that. That is why it is not rational to give more iron with an idea that you may correct anemia faster. It is not possible, right? So what do we use? You have hundreds of preparation in the market: ferrous fumarate, ferrous sulfate, ferrous gluconate. The government of India has comfortably chosen ferrous sulfate for the reason that it provides a good amount of iron. It contains almost 30% of the elemental iron, plus its cost. Fumarate, though it gives little more iron, but its cost is more. Gluconate cost is more. And whatever that is available nowadays, the other ones, carbonyl iron, iron polymaltose complex, ferrous glycine sulfate, all are poor, more expensive but poorly absorbed. You may have heard of some of the sustained release tablets. People say you just give the sustained release or enteric coated tablet, which is going to be very beneficial as it doesn't cause any gastric reaction. Students, the absorption of iron happens in the duodenum. So if you protect the iron from getting released in the duodenum, if it goes beyond that, iron is not absorbed. That's why on the lighter side, I would always say that if there is no side effect, probably, believe me, there won't be any effect also. So it's a waste. Totally the iron preparations which are enteric coated will go a waste. It just goes out in the stools without getting even absorbed. So better we use the commonly used and the cheapest preparation that is available, that is ferrous sulfate. Unless the patient is not able to tolerate ferrous sulfate, you can change over to some other salt, right? So always, how you advise, just don't hand over the tablets of iron and send her. It is to be taken on empty stomach early in the morning or at least 2 hours after food, preferably with vitamin C. So you can ask her to take it with a glass of lemon juice or sweet lime juice or orange juice or something which improves the absorption. It should not be given with food, right? Especially phosphates, phytates, tannates, coffee, tea, milk, everything is going to hinder the absorption of iron. Avoid with calcium. Normally we give calcium with iron for a pregnant woman. Ask them not to take them together. Don't give them with thyroid supplements also. There are certain other things like antacids, H2 receptor blockers, proton pump inhibitors, milk and dairy products. All calcium supplements, thyroxines and quinolones should not be used along with iron because it's going to be coming in the way of iron absorption. So the one which helps in the absorption is vitamin C. So ask her to take it with food rich in vitamin C. Of course, nausea, constipation, discoloration of stools, diarrhea, epigastric distress, vomiting can occur with iron. But believe me, students, if you tell that you may have side effects, our pregnant women will have side effects. If you say nothing is going to happen, this is wonderful, nothing is going to happen. There is a psychological element for these things that is available free of cost. They may expect a lot of things to happen. So you always don't warn them with any kind of possibility of side effects. You just tell them, if you have any problem, you just come back to me. I don't expect anything to happen to you with these tablets, right? And the best way to know whether she is taking tablet or not is ask her what is the color of her stools. Women taking iron will pass dark colored stools. Don't tell them that you will pass dark colored stools. Just send them. They themselves might come and say, I am passing dark color stools, which confirms that they are taking something available free. We are worried whether they will consume it or not, right? So response to therapy is ascertained by an increase in the reticulocyte count, which takes about 7 to 10 days after it starts. By 7 to 10 days, hemoglobin increases by 0.3 to 1 gram per deciliter per week. Usually around 3 weeks, you estimate the hemoglobin, you expect a good observable change. If there is no improvement in the hemoglobin in spite of taking iron, first of all, make sure that she is taking the tablets properly. Later on, see whether there is anything that is continuing the loss, like hookworm infestation and any other deficiency. So this is the time you start working up with other investigations. Rule out hemolytic anemias or other trace element deficiencies. Now coming to the second route of therapy, injectable iron. So injectable iron need not be used very frequently, right? It is reserved for certain situations when the patient is not responsive to oral therapy, and when you are sure that she is totally non-compliant or she is not tolerating oral iron. Sometimes I said, the stomach hydrochloric acid and also the duodenal part is very important for absorption. But if there is any malabsorption syndrome or gastrectomy or any such thing has happened, in such cases, you may have to go for parenteral iron, right? Government of India recommends for moderate anemia or after 20 weeks of gestation, the ideal route would be using injectable iron. This is the NRHM recommendation. I would repeat it again after some time. But parenteral iron, you cannot give the same dose to everyone. You are supposed to calculate using a formula. Students should know about this formula, and the formula says total dose of iron required is 2.4 into pre-pregnant weight in kgs. So this is important. Pre-pregnant weight you should know. You should not calculate it for the weight at that point of pregnancy. Pre-pregnant weight you should know. If you do not know the pre-pregnancy weight, at least the first trimester pregnancy weight can be taken. And that should be multiplied again with the hemoglobin deficit. So how do you know the hemoglobin deficit? Take 11 grams as the standard level, and if her hemoglobin is 8 grams, you have to say 11 minus 8, which comes to about 3. 3 is the deficit. So here you put 3 and add 500 milligrams at the end for storage, right? The same thing, you have one more formula. This was the one which was earlier used. It was 0.3 into pre-pregnant weight into hemoglobin deficit plus 1000 milligram. Storage could be either 500 or 1000 milligram, right? So it depends on the hospital practice. Now, I have given an example. If the hemoglobin is 7.5 grams, and let us assume her pre-pregnancy weight to be 50 kgs, the dose required is 2.4 is a constant. So for anybody, you are going to put 2.4 into her pre-pregnancy weight was 50 into 3.5 is the deficit because it is 11 minus 7.5. And when you add 500 to this multiplication comes to around 420 plus 500 comes to 920 milligrams, right? So whenever you get this kind of number, whatever is the number, let it be 600, 800, 1200, we are not usually giving all the iron in a single shot. Usually 100 or 200 milligram ampules that are available will be diluted in 100 or 200 ml of normal saline and intravenously. It is given directly for within 15 to 20 minutes. Very important. Number one, it is IV. Number two, it is given in dilution in normal saline. Number three, it should be quickly finished in 15 to 20 minutes. There is no need for test dose giving, right? So with these things, you totally calculate. For example, if you are giving it for giving 100 milligram per day or on alternate days, you have to call her 9 times to take this injection. Now we have ferric carboxymaltose, which is available as 500 and 1000 milligrams direct. So which can be more comfortable and convenient for the patient. So she can take 1 or 2 injections depending on the requirement and availability of the strength of FCM with the hospital stores. Now coming to the third mode of treatment, that is blood transfusion, or I would prefer to call it packed cell transfusion. We don't give whole blood for anemic patients anymore. We give only packed cells, and that is the preferred mode for all severe anemias. Any trimester, if the patient comes with severe anemia, you have to give, right? Hemoglobin less than 7 grams in late third trimester also, even moderate. If she is coming in the late third trimester, we give blood packed cell transfusion, because she will be close to delivery, and iron will take, as I said, whether it is intravenous iron or oral iron, it takes about 2 to 3 weeks to correct the hemoglobin. So if you don't have 2 to 3 weeks to correct the hemoglobin level, you better give blood transfusion. Blood transfusion has to be very carefully given at the rate of 80 to 100 ml per hour, completed in about 3 to 4 hours. Right? There is something called exchange transfusion. Just a word about it. I don't think it is practiced anywhere in India, but it is being practiced in certain hospitals in Western countries. What they do is they remove some amount of blood from the woman, and they transfuse from the other vein good amount of good hematocrit blood, right? Because she has got very low hemoglobin, that would be removed out, because it should not cause overload. So women in failure are the best candidates for this. So remove 100 ml and give about 80 or 75 ml to decrease the load but improve the oxygen carrying capacity. So this is called exchange transfusion, has a small role, not at a popular one here. Earlier it used to be there, but nowadays we are no longer following it, right? The other interventions, can we go ahead with induction of labor in anemia? See, usually they are more prone for preterm labor. So there is very rarely a need for induction, but if there is a need, you can induce labor. Augmentation also is not necessary in most of the cases because they progress very quickly, but in case it is necessary, you can give, but be careful while using oxytocin and giving fluids, because they can go for pulmonary edema and can die during labor. Antenatal steroids, if necessary, can be safely given. Fetal monitoring also need not be continuous, but if there is a need for fetal monitoring, you individualize the condition. It is not that always they come only with anemia. They may have other problems also. Always anticipate and look for infections and energetically treat, right? Intrapartum monitoring, when she is in labor, close monitoring for fluid overload, oxygen if the saturation falls below 95%. So avoid fluid overload. Don't repeatedly keep doing vaginal examination to assess the progress, because you may introduce infection. Second stage prolongation is usually avoided in case of severe anemia, and if the patient is in failure, better to use an instrumental delivery to avoid her from overstraining. Active management of third stage of labor should be performed to prevent excess blood loss. Oxytocics should be administered to prevent third stage hemorrhage. So just to summarize what we do obstetrically: first stage, propped up position, keep blood ready, prophylactic antibiotics, oxygen if necessary, don't overload with fluids, reduce her anxiety by giving labor analgesia, don't forget to plot a partograph, very, very important. Second stage, try to avoid episiotomy because that blood loss also may not be tolerated. Consider instrumental delivery in certain cases. Continue monitoring the pulse, BP and respiration. Give the position of comfort to the patient and always make blood available. Third stage, active management of third stage. Keep a watch for PPH, carefully monitor use of other ecbolics like misoprostol or PGF2 alpha. Avoid methyl ergometrin. Energetic management of PPH if at all it occurs. Postnatally, use antibiotics. Repeat hemoglobin after 48 hours and look for it, and take care to avoid deep vein thrombosis, which is a big risk in anemia and puerperium. Subinvolution and lactation failure are common problems. protein-rich diet to be given. If the patient is non-compliant, in the postnatal period, you can consider intravenous iron, give her iron and send, instead of asking her to take iron for 3 months if she is non-compliant. Ferric carboxymaltose, which is available as 1000 milligram and 500 milligram, could be a very good alternative for these women. Coming to contraception, adequate spacing of pregnancies should be encouraged. So immediately after delivery, you can consider progesterone only pill injection, medroxyprogesterone, or you can use postpartum IUCD and advise them lactational amenorrhea method for contraception, right? But after 6 months, advise oral contraceptive pills, but be careful because it can increase the chances of thromboembolism. If she is a multiparous woman, you encourage tubal ligation. So to summarize the treatment, mild, moderate, severe anemia, first trimester, second trimester, and third trimester. In third trimester, up to 36 weeks and more than 36 weeks. See, you just remember the pattern I have given. Upper 3, right? Upper 3 squares, oral iron. Or let me make it very simple now. After 36 weeks, any anemia, blood transfusion. Any trimester, severe anemia, you are giving transfusion. See, look at these things. Severe anemia in any kind trimester, you are giving blood, and more than 36 weeks, you are giving blood. Then first trimester, you just consider oral iron because oral iron can worsen her vomiting. So if it is tolerated, you can give oral iron again if tolerated. Second trimester, mild anemia, you can treat with oral iron, but Government of India recommends that oral or injectable iron has to be considered in the other situations. I have put it in different colors. So just remember this. Remember this table. This totally summarizes the treatment schedule. This is NRHM. Again, very simple. Just see, students, more than 11. You are giving them only prophylactic iron. Hope I am clear with this. Prophylactic iron is giving 100 milligrams of elemental iron throughout pregnancy from 14 weeks onwards. Now less than 7, always give them packed cell transfusion at any duration of pregnancy. So more than 11 and less than 7, we are clear. 9 to 11, you are giving therapeutic iron in all the trimesters. If that is 9 grams to 11 grams, you are giving therapeutic iron. But 7.1 to 8.9, you are going to consider therapeutic iron 14 to 16 weeks oral, but beyond 20 weeks, it is injection. And of course, beyond 30 weeks, the NRHM recommends blood transfusion. So if you just remember this table, it becomes easy for you. And usually the case that you get in the examination would be a third trimester with anemia case. So the management would be to go ahead with either blood transfusion or early trimester, you can go for the problem with, the option of injectable iron. So I think it is time now. Let us just take the opinion. Shall we conclude here? Because I still have another 10 to 15 slides if the other aspects of anemia needs to be dealt with. But for undergraduates, it is more than enough if they know well about iron deficiency and 1 or 2 sentences about the other anemias. Can I just take the collective opinion, please?